November is National Alzheimer's Disease Awareness Month. But Alzheimer's and other forms of dementia can strike at any time. In this video, Dr. Abby Altman, geropsychologist at Brigham and Women's Hospital in Boston, details the behavioral and psychiatric symptoms of dementia. She also explains what makes these symptoms so difficult to manage, what model family and caregivers can follow to help manage these symptoms, and the steps you can use to increase the security of a loved one exhibiting dementia. Because I'm in Los Angeles and Dr. Altman is in Boston, we'll be conducting the interview via Zoom. Hi, it's Jeff Hoyt, editor-in-chief of SeniorLiving.Org, and today I have the pleasure of speaking with Dr. Abby Altman. She's a geropsychologist at Brigham's and Women's Hospital in Boston. Welcome, Dr. Altman.
Hi there. Good to talk to you again.
Glad you could make it. So we want to talk about dementia in general, and we have a lot of issues with caregivers having to deal with a loved one, a parent, a grandparent, family member, spouse. And as someone's dementia progresses, what can be the most challenging parts for the caregiver or the family?
You know, when I work with caregivers, I think just sort of a general theme and something that comes up quite a lot is that no one signed up for this. Like, this isn't something you're like, yay, I really wish my loved one gets dementia. It's something you sort of never wish or want for somebody you love. And unfortunately, it is a common diagnosis that individuals are diagnosed with and carry. I think a term that I reference a lot is this concept of ambiguous loss that happens in dementia. It's a term coined by Dr. Pauline Boss. And it's this concept that it is loss. This is grief where the individual is there, but they're not the same person anymore. There are changes that have happened, and that is very sad as well as challenging, especially when the disease progresses. And I think kind of one of the bigger challenges or themes within that are these behavioral and psychiatric changes that happen in dementia that are very common in about 90% of dementia cases and definitely presents more as the disease progresses.
So what are the behavioral and psychiatric symptoms of dementia?
Yeah, so there's quite a few that we could notice and look out for. One would be agitation. So somebody acting more agitated than they have before, or just new onset agitation. Another one would be wandering. So an individual wandering, moving around sort of aimlessly or just sort of out of nowhere and possibly in unsafe ways. And in general, there's an increased sense of restlessness in the individual as well. Repetitive behavior is another common behavioral and psychiatric symptom of dementia, where someone's doing something over and over again, asking the same question over and over again, or a task like hoarding is kind of a common one where it's just they're collecting things for like sort of no apparent reason. Mood disturbance too. So depression or anxiety, I mean, that might have been there for an individual, but it could also be new and not present before. Behavior that would be also socially maybe inappropriate, like blurting things out that are kind of a little taboo or unlike the individual, would also fit into that category. Physical aggression, so somebody who was never ever physical before, all of a sudden acting aggressively physically towards anyone, loved ones included. Psychosis, this one does happen, unfortunately, where somebody might see things that aren't there. There may be delusions and other types of just psychotic-like behavior. And also sleep disturbance. We put that in this category too, where somebody is just having some pretty drastic changes in their sleep, sleeping more, sleeping less, and that would also be considered a behavioral and psychiatric symptom of dementia.
Right, and in combination, someone having, sleep disorders and then wandering or agitation, this is happening when the family is asleep. It just makes it even more difficult to manage.
Yes, definitely. A lot of this is unexpected, and and kind of happens sometimes out of nowhere and out of character of the loved one. So you could understand that this would be challenging and at times disturbing for the individuals in that person's life.
And what else makes them difficult to manage?
I said it a little bit before, because they're so out of character. It can be like, what has happened to my loved one? It amps up that sense of loss that this wasn't there before, and now it is. The other thing that you kind of see on the flip side of it is some of this may have been there before. Like, you might have had a loved one who had some agitation or impulsivity or did things without thinking. I guess that's impulsivity, or maybe some other behavioral symptoms, and you see it more now, and it's upsetting to see. So it seems like this is being done on purpose, like there's a purposefulness in the behavior, like almost they're out to get you or doing this to upset you. And with dementia, the one thing we very clearly know is insight is impaired. So the intentionality of these behaviors that can't exist anymore. It's not like somebody's doing this to upset you, but already when you're dealing with caregiving and this extra burden and stress, that can get a bit confusing and challenging, understandably, when these behaviors are happening and they were maybe characteristics of the individual before, but now they're exaggerated and possibly seen purposeful when they are not.
And from the caregiver perspective, you've written about the DICE model before. Do you want to expound on that somewhat?
Yes. So with these behavioral and psychiatric symptoms of dementia, because they're happening because of dementia and insight is impaired, we like to address these. I know in my practice, I use this a lot, where we're understanding that because insight is impaired, it's important to address these from looking at, all right, what other factors are contributing to these behaviors? How could we maybe change the environment, psychological factors, understand things medically, and look at that as a scientist, in a sense, to better to shift it possibly, or get some reduction in the behavior. So the DICE model is one type of behavior management approach created by Dr. Helen Kales. And it helps us think through this 4-step model where we're first describing. So the D in the DICE is describing what happens, the behavior. So just really looking at it and understanding it. The I stands for investigating the possible causes. So why might this be happening? Of course, as a scientist, it's a guess, possibly, or maybe true. C is creating a plan to address it. So based on your knowledge of what you observed and what you're thinking it might be about, coming up with a plan. And then E is evaluating the plan. So like as a scientist, trying to look at it and say, all right, if I approach this in this way or understand it in this way, does it make a difference?
And can you give us any examples of that, how the DICE model might look in action?
Sure. Right now I work at Brigham and Women's, but in previous jobs in nursing homes, there was I remember one real interesting experience where there was a resident who she wasn't eating, like food was in front of her and she didn't seem to have a desire to eat. So when we're describing the situation, so individual not eating or not eating as much as they would hope, kind of a little unsure around mealtime, not really motivated to eat. So that's a way we would describe the situation, getting data. It was around each mealtime. It wasn't just one mealtime in particular. So that was the D in the model. And investigating, as we're investigating what's happening, we noticed that she was seeming just a little confused, like, what is this? But it seemed to be looking like she knew it was food, but sort of didn't know what to do with it at that current moment. And so in creating the plan, what we thought about, which we try to do a lot, is understand what somebody like, what's their history? What's important to them? Who are they? And one key thing about this individual was that she loved to cook. Like, so we have food and we have somebody's relationship with food. And so we thought, all right, let's be creative here and try to bring in her relationship with food, her love of cooking, to see if that can make a difference. So our plan was to ask her, instead of please eat or eat, is this salty? Is this sweet? And that encouraged her to take bites. She wanted to let us know. She wanted to see if it needed more seasoning. We'd ask, would you put more salt in this? What does this need? What spice does this need? And she would answer and she would take bites. So although it was more about her trying to answer us, she was eating, which was the most important thing because we wanted her to eat. And it made it a little more enjoyable for the staff and family working with her and engaging with her at the time. And so when we're evaluating the plan, it led to more eating, led to the goals that we'd want for someone to be able to get nutrition. So that would be an example of the DICE model in action.
Great. So in closing, I'm just wondering, as a family member, not a professional caregiver, what concrete steps can people take when they see signs of dementia, or increase the security to take care of the person who's suffering from dementia?
You know, a lot of times with dementia, especially as it progresses, concerns around like, can this person hurt themselves, harm themselves, like, especially with wandering. I know I wrote an article about that. We don't want someone to just exit the house and walk into traffic. I mean, that's scary and frightening. But I think this also speaks to concepts of the DICE model, which is we might not be able to change that loss of insight, but what can we do in the environment, or how we ourselves can change to help someone be a bit safer? So for instance, you might camouflage doors in creative ways, paint murals on doors, change the colors of doors. So just it visually looks different, which might make it, in a sense, less appealing for them, or might make it that it's not as obvious that it's a door for them to exit. You could, of course, make things safer in terms of like ovens and things that might have risk of putting things on, putting safety features on things that are more unsafe, car keys, take away. Of course, with car keys, underneath it all, somebody who, right, it's not that they're, the memories, people have routines and they remember this. So the urge to drive might be there, even though they can't. So bringing some understanding and compassion to that, of course, is key. I think what you see in some of what I'm describing here, focusing less on words or verbal communication to try to redirect somebody, but visual cues can be really useful to help with safety. So putting up stop signs or having visual cues on doors to prevent exits if we're concerned that somebody might wander off. So they would see a stop sign, and that kind of cue, like a visual cue like that, is overlearned and generally not forgotten as somebody's dementia progresses, what a stop sign means, and that generally you wouldn't go through that space. Otherwise, I think in general, things that I've found to be really helpful for individuals with dementia, continuing with routines, structure will help, and just having sort of a set day to day and what you do, and that be clearly written, even with a schedule on a board, setting alarms or having lights go off when you want certain things to happen. That could be useful for individuals. Also, with information you might get from the DICE model or other behavior management approaches, you might know certain times of the day that someone might wander more or be more restless. And so during those times, you just might want to have activities that they like, so to decrease the likelihood someone might wander off or do something unsafe. And in general, I think having a calm environment, an environment with less maybe distraction and stimulation in general, can settle somebody down, and maybe decrease the likelihood of unsafe behaviors as well.
Great. Well, we really appreciate you helping to promote safety. and shine a light on this issue for seniors. Thank you very much, Doctor. Really appreciate you taking the time.
Thank you.